Imagine, you finally get your menopause symptoms under control. The brain fog lifts, the hot flushes stop. You just, you feel like yourself again.
Right, you finally have your life back.
Exactly. And then out of nowhere, sudden, unexpected vaginal bleeding.
Oh, yeah.
Your first instinct is just absolute panic. I mean, the immediate thought is that something is terribly wrong.
It completely disrupts that hard-won peace of mind. The
Mhm.
anxiety it causes is, well, it's profound.
Right. But what if I told you that for nearly half of all women on hormone replacement therapy, this terrifying symptom is actually a completely standard part of the process?
Yeah. And the clinical response to that panic isn't chaos. It is actually a highly structured, evidence-based process of elimination.
Which is exactly why we're here. Welcome to today's deep dive. Our mission today is to cut through that anxiety for you. We are going to crack open the clinical guidelines, specifically looking at the British Menopause Society, NICE, and local NHS cancer alliances, and figure out exactly how clinicians investigate and manage unscheduled bleeding when you're on systemic HRT.
Right.
We're talking about the step-by-step clinical detective work required to, separate a harmless side effect from a serious underlying risk. And to kick us off, I have a statistic that completely blew my mind.
Let's hear it.
Unscheduled bleeding affects approximately 38% of people using sequential HRT and a massive 41% of people using continuous combined HRT.
I mean, that is nearly half of all patients on continuous combined regimens. It's incredibly common.
It's huge.
It is. But just because it is common does not mean a clinician can simply brush it off, right?
Yeah.
A symptom like this kicks off a very specific triage process because the stakes are high, even if the odds are, well, heavily in your favor.
Okay, so since this bleeding is so common, how does a doctor even know where to begin? Like, when you present with this symptom, they don't just immediately rush you into an operating room.
Oh, definitely not. They start with a comprehensive initial clinical assessment. They need the exact bleeding pattern.
Right, like, is it light spotting? Is it flooding?
Exactly. They want to know exactly what HRT preparations you are on, how long you've been on them, and crucially, if you're experiencing any pelvic pain.
And they are also offering physical examinations right out of the gate, right?
Yes, that means checking the abdomen and pelvis, looking at your BMI, and seeing if you're due for cervical screening or maybe need any swabs to rule out underlying infections.
Okay, let's unpack this because it reminds me of IT troubleshooting.
IT troubleshooting.
Yeah. You know when your computer crashes and you call tech support panicking about a fried motherboard and the very first thing they ask is it plugged in?
That is actually a perfect analogy. Before they tear apart the hardware, they check the basics. In the clinic, we call this checking compliance.
Right. Like, are you actually taking the medication correctly?
Exactly. Are the hormone patches sticking to your skin, or are they, falling off in the shower? Or are the pills being taken at the right times every single day?
Because a sudden drop in hormone levels, just from a patch peeling off or a missed pill, can easily trigger withdrawal bleeding.
Absolutely.
Yeah.
But the clinician is also looking for hidden factors that might be messing with the wiring, to stick with your analogy. They are looking at your entire medical profile, not just your HRT.
And what's really surprising when you look at the pharmacology here is how other, seemingly completely unrelated medications can interfere.
Oh, for sure.
Like, one of the biggest culprits right now is Mounjaro or Tirzepatide. This is that dual action injection that has become hugely popular for diabetes and weight loss.
Right, and what's fascinating here is the underlying mechanism of that drug interaction. Mounjaro and other drugs in that GLP-1 class work in part by delaying gastric emptying.
Meaning they physically slow down how fast your stomach empties its contents into your intestines.
Exactly, which is great for making you feel full and managing those blood sugar spikes.
But if you are taking your HRT orally, as a pill, that delayed gastric emptying changes the whole equation, doesn't it?
It really does. If the pill is just sitting in your stomach acid for longer than it's supposed to, the active hormones can degrade before they ever reach the intestines where they are actually absorbed.
Wow, so you might be swallowing the pill every single day, but your body isn't getting the full therapeutic dose into your bloodstream.
Right, and if your body isn't getting the full dose of progesterone, it is not adequately protecting the lining of your womb, the endometrium.
The builder and the protector, which we'll get to.
Exactly. The HRT becomes less effective at stabilizing that lining, which directly leads to unscheduled bleeding. The safest clinical pivot in this scenario is to switch the patient to non-oral transdermal HRT options.
Think patches, gels, or sprays, because transdermal options bypass the digestive system entirely.
Yes, The hormones absorb directly through the skin into the bloodstream, so it doesn't matter how slow your stomach is emptying.
It completely sidesteps the interference.
It really does. It's a perfect example of why clinicians have to look at the whole patient.
Okay, so you come in for bleeding, and the culprit might actually just be your weight loss injection. But let's say your patches are sticking perfectly, your pills are absorbing fine, and there are absolutely no sneaky drug interactions. The clinician now has to decide, is this bleeding an actual red flag?
Right. So once the history is taken, clinicians stratify patients based on specific risk factors for endometrial cancer. And crucially, they look at these risk factors completely independently of the bleeding itself.
They're basically building a profile of your baseline biological risk.
Exactly.
And when clinicians look at risk, they divide it into two buckets, right? Major and minor risk factors. Some of them make total intuitive sense. Like a major risk factor is a body mass index, a BMI of 40 or higher.
Yeah, and we should actually look at why BMI plays such a huge role here. Adipose tissue, or body fat, isn't just inert storage. It is hormonally active.
Wait, really?
Yeah, it contains an enzyme called aromatase. And what aromatase does is it takes circulating androgens, which are male hormones that women naturally produce, and converts them into a type of estrogen called estrone.
Oh, wow. So someone with a higher BMI is constantly producing their own background level of estrogen.
Exactly.
Oh, so they are getting the estrogen from the HRT, plus this extra estrogen from their own fat cells. That completely tips the scales.
It does. And there are also genetic predispositions on the major risk list, like Lynch or Cowden syndrome.
Right, and for anyone who hasn't encountered those terms, Lynch syndrome is an inherited genetic condition that affects the body's ability to repair DNA mistakes, which drastically increases the risk of certain cancers, particularly colon and endometrial cancer.
And Cowden syndrome involves a mutation in a specific tumor suppressor gene, which also elevates that baseline risk. If a patient has these genetic profiles, the clinical algorithm immediately places them in a high priority category.
Okay, but then there are the risk factors related to the HRT itself. Taking estrogen-only HRT for more than 6 months if you still have a uterus is a major risk.
Yes, definitely.
And so is tricycling your HRT for more than 12 months. Tricycling is when you take daily estrogen, but you only take the protective progesterone every 3 months to induce a quarterly bleed instead of a monthly one, right?
That's right. And then the minor risk factors include things like a BMI between 30 and 39, having diabetes, or having conditions with unovulatory cycles like polycystic ovary syndrome, PCOS.
Okay, wait, I'm getting hung up on something here.
That's that.
Wait, so the exact same hormones used to treat the symptoms can actually become a minor or major risk factor if the recipe isn't perfectly balanced. Like, isn't estrogen the exact thing we're prescribing to fix the menopause symptoms? How does the cure become the risk?
It's a great question. And it's why knowledge is most valuable when it's understood and applied safely. The fundamental biological mechanism here is a delicate dance between two hormones, estrogen and progesterone.
Okay.
Think of estrogen as the builder. It proliferates and thickens the lining of the womb. So that same hormone that is relieving your systemic menopause symptoms is locally doing renovation work in the uterus.
Right, it's building up that tissue.
Exactly. Progesterone, on the other hand, is the protector. Its job is to counteract that building process, stabilizing the lining and eventually causing it to shed, which is your period.
Ah, I see.
If that balance is off, if you have unopposed estrogen, meaning estrogen without enough progesterone to keep it in check, the lining just keeps building. And that unchecked proliferation is what increases the risk of abnormal cells developing.
So bringing it back to tricycling, if you only take progesterone every 3 months, you are letting the estrogen build that lining unchecked for 90 days at a time.
Exactly.
And doing that for over a year pushes the building process to a point where it becomes a major risk. And having PCOS, where you aren't ovulating regularly and therefore your body isn't producing its own natural protective progesterone, that's a minor risk factor because your internal balance is already tipped toward estrogen.
You got it. The clinician is essentially looking at your life, your genetics, and your medications, and calculating how much building has been happening and has there been enough protecting going on.
Okay, so the doctor has your history, they've checked your patches, they've tallied up your major and minor risk factors. What happens next? Like, how do they actually look inside to see what's going on?
Well, this risk calculation dictates the timeline for the next diagnostic tool, which is the transvaginal ultrasound, or TVS.
Okay.
And the guidelines are incredibly specific about how fast this imaging needs to happen.
Right. First off, there is what I like to call the 6-month grace period.
Yes.
If you are within the first 6 months of starting HRT or within the first 3 months of changing your dose or preparation and you have no specific risk factors, clinicians will often manage the bleeding conservatively. They basically tweak your HRT recipe and give your body time to adjust.
Because early bleeding is incredibly common as the endometrial receptors acclimatize to the new hormonal environment.
The body is literally rewiring its response.
Exactly. Rushing to invasive tests immediately during this adaptation phase just isn't clinically sound unless there are other red flags.
But if you fall outside that grace period, the clock starts ticking. There is the urgent TVS pathway, which means you need an ultrasound scan within 6 weeks.
Right.
And this happens if the bleeding starts after you've been on HRT for 6 months, or if it's been more than 3 months since a dose change. It also triggers if the bleeding is notably heavy or persistent, or, and here's where that math comes back, if you have 2 of those minor risk factors we tallied up earlier.
And then there is the fastest route, the urgent suspicion of cancer pathway, or the USCP.
Right, the 28-day one.
Yes, this mandates a specialist assessment within 28 days.
Oh.
This is triggered immediately, regardless of when you started HRT, if you have just one major risk factor or 3 minor risk factors.
Okay, and when they actually do the transvaginal ultrasound, the radiologist is measuring something very specific, right? The endometrial thickness, or ET. And here's where it gets really interesting, because the precision of this clinical algorithm is just amazing.
It really is.
They don't just look for, like, thick or thin. They're looking for specific millimeter thresholds.
Yes, sir.
If you are on continuous combined HRT, meaning you take a steady dose of estrogen and progesterone every single day, a normal thickness is 4 millimeters or less. But if you are on sequential HRT, where you mimic a cycle and have a planned monthly bleed, a normal measurement is up to 7 millimeters.
And that difference is crucial because of the biological goals of those regimens. On sequential HRT, the lining is supposed to be a bit thicker before it sheds during the withdrawal bleed.
That makes sense.
If the ultrasound shows measurements above those strict 4 millimeter or 7 millimeter thresholds, it triggers further investigation. Usually that means an endometrial biopsy or a hysteroscopy.
Where they insert a tiny camera into the uterus to look at the tissue directly, right?
Yes, and they take a physical sample to examine microscopically.
But, I mean, hearing terms like urgent suspicion of cancer pathway is terrifying for a patient. It sounds like a death sentence before you even get the scan.
Oh, it is terrifying.
Yeah.
But if we connect this to the bigger picture, these pathways do not mean a patient has cancer.
Right.
That is the most important takeaway for anyone navigating this. These pathways are essentially highly sensitive triage systems. They are designed to cast a wide net, ensuring that anyone with even a slightly elevated risk profile gets prioritized.
It's like airport security swabbing your hands because you packed a large bottle of shampoo. It doesn't mean you're a threat. It just means the system is incredibly sensitive and designed to flag anything slightly out of the ordinary so they can take a closer look.
That's a great way to put it. The system is deliberately designed to overreact on your behalf. The entire architecture of these clinical guidelines is built to get the right patient to the right clinic at exactly the right time. The goal is to minimize the time you spend anxious while maximizing your physical safety.
All right, so let's say you go through the pathways. You get the ultrasound, maybe even the biopsy, and the results come back totally normal. Or let's say you are just in that 6-month grace period and don't need a scan yet. You don't have cancer, which is the best news ever, but you are still dealing with unscheduled bleeding. How does the clinician actually get it to stop?
This is where we move from investigation back to active management. The primary goal is restoring that balance we discussed earlier, ensuring the progestogen dose is proportionate to the estrogen dose.
So it can adequately protect the lining, thin it out, and stop the bleeding.
Exactly.
The guidelines actually lay out some very specific hormonal adjustments. One option is significantly increasing the protective hormone. They might prescribe 300 milligrams of micronized progesterone for 14 days out of every 28-day cycle.
Yes.
And let's define micronized progesterone. This isn't a synthetic chemical, it's bioidentical, usually derived from plant sources like yams. The molecules are physically milled down or micronized, so they can be easily and efficiently absorbed through the digestive tract.
But if the body isn't responding well to that bioidentical progesterone, the clinician might switch you to a synthetic progestogen.
Why is that?
Because synthetic versions are often more potent at stabilizing the endometrium. Clinicians might prescribe preparations like Everol Sequi, which is a specific brand of patch that delivers both estrogen and a potent synthetic progestogen. Or they might just add an extra progestogen pill daily for 3 months to really reinforce that endometrial protection and force the lining to stabilize.
And then there is the heavy hitter, which the guidelines highly recommend, the 52 milligram LNG IUD. This is a hormonal coil, most commonly known by the brand name Mirena.
The levonorgestrel intrauterine device is often a game changer.
Really?
Oh yeah, because it sits directly inside the uterus. It delivers a steady, highly concentrated dose of progestogen exactly where it's needed most to thin the lining.
Oh, I see. Rather than taking a pill where the hormone has to travel through your stomach, your liver, and your entire bloodstream just to reach your uterus.
Exactly. It achieves profound local endometrial protection without having to flood the rest of the body with high systemic doses. It is highly effective for controlling that unscheduled bleeding.
But the clinical guidelines also address a very real human scenario. What if a patient just says, no, I don't want the transvaginal ultrasound. I don't want a biopsy. I'm done.
Patient autonomy is absolutely central to modern clinical care. If a patient declines investigations, the clinician's job isn't to force them. It's to explore the barriers.
Like, why are they declining?
Right. Is it fear of pain during a biopsy? Is it past medical trauma? There are often profound, valid reasons for refusing these procedures. But ultimately, if the risk cannot be safely investigated, the medical recommendation is to begin weaning the patient off the HRT.
They don't just cut you cold turkey, though, do they?
No. Dropping hormone levels rapidly can cause severe symptom rebound. They gradually reduce the dose, offer non-hormonal alternatives to help manage the returning menopause symptoms, and they mandate a follow-up appointment in 4 weeks.
Because they need to see if the bleeding has stopped now that the external hormones are out of the system.
Exactly.
So what does this all mean? I mean, it means that managing HRT is absolutely not a set it and forget it prescription. It is a dynamic, ongoing conversation and partnership between you and your doctor.
And this raises an important question directly for you listening right now. What stands out to you about this entire process? Because the one constant in everything we've discussed is the patient's own awareness.
Yeah, that's true.
This entire rigorous clinical algorithm completely falls apart if the patient isn't actively tracking their own bleeding patterns and communicating those changes. Your daily reality is the most important data point in this entire system.
You really do have to be the squeaky wheel when things change. So let's bring this deep dive to a close. What we've learned today is that experiencing unscheduled bleeding on HRT is incredibly common.
Very common.
But behind the scenes, clinicians are executing a rigorous step-by-step process. They start with detailed history taking and checking for drug interactions. They calculate independent risk stratifications based on your unique biology and medical history. They use incredibly precise ultrasound measurements down to the single millimeter, and they make tailored dynamic hormonal adjustments to get the bleeding under control. It's a system designed to fiercely protect your physical safety while continuously striving to optimize your quality of life.
It is the delicate art of maximizing the profound benefits of HRT while fiercely mitigating the physiological risks.
And I want to leave you with a final thought to ponder. We talked about how modern medicine is introducing incredible new treatments, like those dual-action GLP-1 injections for weight loss and diabetes that slow down digestion. As we saw, these breakthroughs can unexpectedly interact with established treatments like HRT, completely changing how a simple daily pill is absorbed. It really makes you wonder, as our medications become increasingly advanced, highly specific, and deeply interconnected within our bodies, how will the very definition of routine clinical care have to evolve to keep up with this level of polypharmacy? When fixing one symptom in the stomach inadvertently causes a bleeding risk in the uterus, the job of a clinician becomes, well, exponentially harder.
It's a truly complex puzzle for the future of medicine.
Because as we've seen today, when it comes to the human body, things are rarely as simple as a clear, jagged line on an X-ray. The diagnostic landscape might be murky, but the clinical detective work illuminating it is getting sharper every single day.